So on behalf of the Department of Social and Behavioral Sciences here at New York University School of Global Public Health, I'd like to welcome everyone here in the room and online. My name is David Abramson, and I'm a clinical associate professor here in the department and also the director of NYU's Center for Public Health Disaster Science. So at a recent faculty retreat, the social and behavioral faculty decided that we wanted to find a theme, a unifying theme, that we could really explore together as scholars and engage our students and the broader community. And the first theme that we picked was displacement. There are many aspects of displacement, and you're going to hear a very specific one today. So our event today focuses on the public health challenge of displacement caused by the war in Ukraine, which could not be more timely. According to figures released by the United Nations Refugee Agency yesterday, more than 5.2 million people have fled Ukraine since Russia invaded and have been displaced because of the war. An additional 7.7 million have been displaced internally within Ukraine. So altogether, these 13 million people, which is the largest number displaced, is a staggering figure because it amounts to a quarter of Ukraine's population. Today, we've assembled a panel of experts to discuss this humanitarian crisis from several different lenses, including public health disaster science, maltreatment of children, and migration stigma. First, I'd like to welcome our keynote speaker, who joins us live from Ukraine, where it is 9 p.m. Halina Skipalska is Health Right Country Director for Ukraine and the Executive Director of the Ukrainian Foundation for Public Health. She has 13 years experience working in non-governmental organizations in Ukraine with a focus on prevention of HIV/AIDS and the provision of care for vulnerable women and girls. Given the late hour, Halina will speak first and take your questions afterwards and then depart. Our panel of experts will then react to her remarks. Before we begin, Halina wanted to share a video with us from Ukraine.
Thank you. Dear colleagues and guests, we do not refer to calendar dates in Ukraine anymore. We count the days of the war. And the country starts each day with a minute of silence to commemorate those who died and were killed on the past day. Today, on the 62nd day of the Russian war on Ukraine, I showed you a 6-week-old video. Sadly, this video is still relevant and well represented the fear and horror that my country and the people suffer. No one could imagine that this is in 21st century. My name is Halina Skipalska, and I am Health Right International Country Director and Executive Director of the Ukrainian Foundation for Public Health. For more than 20 years, I have been trying to make this world better, to make Ukraine a better country where human rights are meaningful and ensured, where the right to health is transformed into longer and happier lives. All these efforts, as well as the work of hundreds of my colleagues from various sectors of public health, have been wasted and ruined by the will of a dictator, and regrettably millions of Russians who support his autocratic regime and cure war. Those we face here in Ukraine absolutely new realities that are still not well understood and addressed. The war seems to avert any development work in public health. All our efforts should now be directed to response to the emerging health risks for millions of displaced people and refugees. Thus, our new reality looks like the following. 60% of all population are internally displaced, 4.9 million became refugees, and nearly 3 million actively consider leaving their place of residence due to the war. And this is old data. Today was announced another numbers, higher numbers. Since the Second World War, the world has not seen such an unprecedented displacement of the people. Since then, Ukraine has never seen such dramatic changes in public health priorities taking place just in a couple of weeks, and so many challenges that need to be addressed. As you can see here, 60% of IDPs are women, 24% are children of 1 to 5 years old, and 49% are children aged 5-17. 57% are persons under 60, and 20% are people with disabilities. 30% of IDPs are reported chronic disease. For instance, 80% of Kyiv office staff, about 20 persons, relocated to safer regions during first months of war. 60% of mobile team staff operating in eastern Ukraine with support of Health Right International are displaced people as their homes have been destroyed. Eastern Ukraine is the region of active hostilities now, so I assume that there will be up to 90% staff of mobile teams who left east of Ukraine. This and other factors make IDPs extremely affected and vulnerable in terms of public health. The following problems should be emphasized: trauma and rehabilitation. Over 400 children and tens of thousands of civilians were wounded by the Russian army. Hospitals are overloaded with patients that are coming every day. Rehabilitation is hardly available in the current situation. Destroyed hospitals' infrastructure also caused disrupted specialized and primary health care to hundreds of thousands. Non-communicable disease. The war has broken, hampered, or disrupted medical supply chains. Those people with diabetes, those on hemodialysis, and certain groups of cancer patients were put at a direct and immediate risk of health deterioration or ever death. Cardiovascular disease. While donors address immediate needs in medications, patients with CVDs, high blood pressure, and respiratory diseases are at risk, while less visible. For example, father of our project coordinator, Anastasia, has had a heart attack and died just after occupation of his village in Kherson on February 25. Vaccine preventable disease. Millions of children are at high risk of missing their routine vaccinations. that will result in an increase in vaccine-preventable diseases in the future. Nutrition. 70% of IDPs rent their apartments and 40% stay at someone's home. Inevitable household income decrease has resulted in different problems in nutrition: unhealthy diet, unbalanced diet, and even malnutrition. 51% of IDPs have already experienced food shortages, and 25% of mothers experienced problems with getting enough food for infants. Here you can see a photo from Bucha, how people used to live during 1 month. Disrupted education cycle. Disrupted education cycles pose significant risks for children of all ages, from social integration and mental health to low motivation and poor educational achievements. In years, it will have a long-standing negative impact on the lives of Ukrainians. Violence and sexual violence. After horrific pictures from Bucha, Irpin, and awful testimonies of rape survivors, the civilized world should consider the creation of a new terminology for these war crimes. There are actually thousands of victims, those who survived. Mental health. Mental health, continued stress, and PTSD are just some to mention, and the true epidemiology is unknown, as half of the nation has been directly affected by the war in this or that way. Divided families. We have never seen so many families living separately. Over 4 million people, 5 million actually people as for today, primarily women and children had to flee Ukraine due to the war. They live independently of other family members. The world has never dealt with such a war and health challenges caused by the war. Also, many good practices exist. They should be tailored and scaled up. Here I have a few slides about Health Right International and Ukrainian Foundation for Public Health work in Ukraine. Health Right International and the Ukrainian Foundation for Public Health continue to provide services during the war. Since the military offensive outbreak, the halfway house team for disadvantaged pregnant women and new mothers in Kiev has remained operational. But the staff has to work remotely. At the beginning of the invasion, our specialists organized the evacuation of all our clients, 6 women with 7 children who lived in halfway house in Kiev, to safer cities or abroad in Europe. The halfway house team helps women with reallocations and starting their lives over in the new places. Our specialists, social workers, psychologists provided assistance through online means. The service center, Health Rights Service Center team has also switched to remote work. Our specialists support women with children in difficult life circumstances, adolescents, families repatriated from Syria, and evacuees. Our clients receive psychological, legal, and humanitarian assistance. Only in March 22, the center provided services to 266 women, 22 adolescents, and 4 families repatriated from Syria. Also, Our GBV psychosocial support mobile teams, we have 13 such teams in East, which are supported by UNICEF, remain operational in the eastern Ukraine. Before the war, they helped to gender-based violence, domestic violence survivors, and now they assist displaced people in solving life and these problems, or life and non-life problems. As the manager of one of mobile teams from Selidovo, Olena Chubar said to me recently. Moreover, we are currently working with UNICEF and are going to create 50 multidisciplinary mobile teams in 11 Western and Central Ukraine cities and communities that actually host the biggest numbers of internally displaced people. As a public health organization, we will have to develop and adopt new strategies and practices to help people in need. I don't know what will be tomorrow, but I know that we need to act fast and be brave. Thank you very much for your attention.
Alina, thank you very much for your presentation. We're going to take questions now, both from those who are here in person as well as those online. While people are sort of marshaling their thoughts, my first question for you, Helena, has to do with those people who are working in the NGOs and in the health and social service agencies like HealthRight. How are they handling the dual impact of being having a huge burden of the IDPs with very complex problems, as well as themselves being potentially victims or susceptible to the violence of war? So how are they sort of handling that combined demand?
We just decided that we have to use work as also kind of rehabilitation for us, I would say. So we're lucky, we have very good team in Ukraine. And I don't just speak about qualified specialists, there were more than 120 psychologists and social workers, core staff, but now we have more than about 200, it seems to me, staff with this new mobile teams. So all people are professionals and also are very much motivated and dedicated to HealthRight mission. And this is like its recipe, so we just work. It took 2 weeks for me to let's say, to speak with all people and to understand who is in which resource and what can do. And yes, and then we started conversations with donors who see that there are a lot of problems among IDPs, and communicate with different organizations like our, and actually defined what we can cover and do, and what services can be provided or needs can be covered by others. As I'm in Kiev now and just returned from meeting with the Deputy Minister of Social Policy, and we agreed that there are so many internally displaced people and such big number of needs, different needs, that there is a lot of work for different organizations. So I understand that it's important to collaborate with others, and there are really a lot of work for different NGOs and also local NGOs.
Hi, Helena, this is Niyati. I don't know if you can see me, but so great to see you. My question is, thank you for this excellent presentation and for being here. I was really wondering about, supplies. When you talked about food insecurity, medicines, hospital supplies, how is it actually continuously coming in? Are people outside sending? Can you talk a little bit more about the aid from all fronts?
So it's differently organized for each region and for each particular city. So for some places like Mariupol, maybe you heard about this known city, city of brave people. So it's absolutely impossible to bring any food and any supplies to Mariupol, for example. It is totally occupied by Russian military, and they do not allow any humanitarian corridors. They do not allow to Ukrainian, even to humanitarian organizations to evacuate people. So speaking about Mariupol, it's not possible. Speaking about Donetsk and Lugansk regions, it's also different. 70% of Lugansk region is currently temporarily occupied. So we cannot bring nothing to some staff which we still have in Lugansk region who works from bomb shelters, for example. But in Donetsk region, situation is different. We found logistic way. We brought some supplies and medicines and food to Dnipro, and then organized 2 mobile teams with big cars and brought these supplies to Kramatorsk, and then they were distributed to some nearest cities which have a lot of evacuees. So it's very different for each city. It's possible to bring food and supplies to Mykolaiv now, to Odessa, but we don't know how it will be in few weeks. Everything will depend on the situation, political situation, and also war. Few weeks ago, it was impossible to bring nothing to Chernihiv. But now I know that different organizations, logistic companies, they bring supplies to Chernihiv, and it seems like Chernihiv, Chernihiv now is under Ukraine. It is Ukrainian city, but it is not occupied. So it's absolutely possible to help to people who are there. Speaking about Kyiv region, some cities which you heard, like Irpin, Bucha. So it's impossible to live there because there are no gas, electricity, and water now. So, but still some people live there, and some were evacuated to Kyiv or to other regions in west of Ukraine. As far as I know, in Mykolaiv, it's another city in south of Ukraine, there is no water. So some humanitarian organizations bring water from Odessa to Mykolaiv. So there are some logistic ways, and using these ways, different international organizations or humanitarian organizations, depending on needs, bring food, supplies, and medicines, or evacuate citizens or those who are in hospitals and want to be evacuated.
I'm thinking of you. Just want to say thank you very much, and thinking of you and your family.
Thank you, Nyati. It's very nice. I'm very glad to hear you.
Thanks.
Melody?
Hi, I'm Melody, and I wanted to ask for those that are internationally displaced, like the 5 to 6 million, which countries they've been typically going to, and if they've been able to support them with their infrastructure, because I understand it could be very overwhelming in terms of like funding and being able to provide shelter and resources. So can you tell us a little bit about that?
I'm sorry, I didn't hear well. Can you say again the end of your question? So shelters, how you can support?
What countries have the internationally displaced refugees been going to, like the cities, countries, and have those governments been able to support them with shelters or food, or have they been overwhelmed as well?
As far as I know, other presenters will speak about this. Also, as far as I know, most of Ukrainian go to European countries. I don't have a statistic here in front of me regarding countries. So as far as I know, Poland, Romania, Slovakia, they have huge numbers of refugees, but it also means that often refugees go through these countries to other countries in Europe. So Europe tries to also to motivate people to move to other countries, not just to stay in Poland. But of course, I understand also that for Ukrainians who are looking for safe place and think how to return soon, it's more, it's optimal way to not to go far from Ukraine, but to stay in some countries like Poland, Romania, with whom we have borders, Moldova, in these countries. So sometimes the language issue is some barrier for refugees to go to Germany, as far as we know from our clients, or to some countries like Switzerland or like this. So it's very different, and governments from these countries, yes, they support refugees which arrive to their countries. And we at HealthRight think how to develop some program which will focus on not only on internally displaced people who stayed in Ukraine, but also on particularly women and children who are refugees and moved to countries with which we have borders.
Jenna.
Yeah, thank you. Thank you, Helena, for your work. I hope to one day meet you in person safely. My question is about trafficking, and I have colleagues who've been working on the border, and what they've been telling me is that they've seen an increase in trafficking because people are posing as families and they've not been vetted properly. And so I'm curious if you have seen or what HealthRight is doing to educate people on the risk of this, and what can be done to help stop it.
Oh, thank you. It's a very good question. Yes, we think of this, and we just launched with support of UN Women, Safe Women Hub project, which will have focus on provision. It will be actually a team of psychologists and social workers who provide services for women survivors of different types of war crimes or gender-based violence. But also one of the goals of this Safe Women Hub is to inform IDPs who are going to other countries to become refugees on different issues related to human trafficking. Because, yes, because we understand that this Ukrainian, particularly women with children, with no income, with no, sometimes people go with nothing to other countries. They don't have nothing, any clothes, any food, even without documents. So of course, all of them are at high risk of trafficking, and we plan to inform them. First step to informing these people was we agreed with national radio, which works 24 hours, that there will be some short information from HealthRight and Ukrainian Foundation for Public Health on such common issues distributed and provided to those who listen to this radio. Probably there will be we try to develop this this type of work, and there will be new probably ideas which we can implement.
Thank you.
Trine, do we have any questions from our online community yet?
No, not right now.
Well, while they're thinking, so Helena, are there any groups who would, before the war, have been marginalized or in some ways ostracized in Ukraine who are part of the IDP community? And if so, how do you sort of respond to that, whether it's people living with HIV/AIDS or gender identity, LGBTQ? Are there groups like that that were marginalized prior, maybe, and then how are they being sort of handled or addressed now in terms of their issues and their ability to get services and feel comfortable and deal with stigma?
Mm-hmm. Yes, there were a lot of vulnerable groups in Ukraine, and we actually used to work with all these groups you mentioned. We provided services before war for women who used drugs, HIV positive women, adolescents with HIV. So now when for clients which we evacuated, of course, we continued to support them remotely, and one of focuses was also to ensure that clients have access to appropriate health services. Psychological can be provided remotely, social also in some kind, I would say remotely, but health, we linked clients to the health services in countries where they come, or in communities, cities in west of Ukraine where they came. Drug addicted, yes, I mentioned it, gender-based violence survivors. We have a very interesting case study story about there were 8 women, Ukrainian refugees from Syria, who came to Ukraine with no documents for their 30 children. There were 8 women with 30 children. And some of them didn't receive documents. So we also helped them to come to Germany and we ensured that they received appropriate health services and also material support. And for them was very important to receive free of charge shelter and in this country, and also legal permission to stay in this country without any documents. So yes, we help to most vulnerable groups and understand that, but to tell you the truth, and this is a reality, that sometimes our clients who now receive our help and support in just 2 months ago were a normal Ukrainian who had a family, had a job, some income, didn't have problems with health, but war changed their lives. Some had injuries, some were raped, some lost everything. So it's now very difficult to say who is more vulnerable. So it seems like most of IDPs are really highly vulnerable.
So I think, Helena, that it's probably very hard for us to understand what it's like to live in the midst of a war, the way you and your colleagues and everybody who has remained in Ukraine is doing. And I wonder if you could give us a sense of how your daily life has changed as a result of this.
Daily life was changed. So first of all, during first 2 weeks, the most important issue for me was, and probably for most of people from Kiev, from east of Ukraine, were safe issues, where I can go to feel that I'm safe. Then it took probably also 2-3 weeks to understand and to how to live with this crazy, I would say crazy, air alarms during nights, because we understand that it's very important to go to shelter or to stay in some safe place in your house. And air alarms we have in all Ukraine, in biggest cities, not just in east of Ukraine or not just in Kiev. So now in Kiev, I'm second day in Kiev, so it's like I feel more safe comparing to Lviv, for example. There were a few missiles previous week in Lviv, so I felt not safe. And another recipe is that or I don't know, maybe it's weakness also. We don't feel weekends. We don't feel our daily life is changed. We cannot walk to forest. We cannot. People like in big cities, they maybe can live like a normal life with the exclusion of the sirens, and when you expect that something bad may happen. And don't go, so we cannot travel as we want. We cannot visit our relatives when we want, because everything depends on road, how it, and people mainly can travel by cars. So there is railway station transportation available, but I feel that it's a little bit unsafe to travel by train. So we don't feel weekends, but this air alarms, I think that it's really not good for us and influence our health, particularly mental health. I heard this from many people, but I'm speaking about myself. I'm lucky my house is. I know many our staff and my friends lost their houses. Their houses were totally destroyed. Houses near Kyiv region, and of course those who have houses in east of Ukraine or in Mykolaiv or in Odessa, for example.
Yeah. Well, Helena, we hope that you and your colleagues and your family and friends all stay safe, and that hopefully this will be a very temporary imposition on your lives, and that your lives can return to some stability and begin the very tough challenge of reconstruction which you have around you. We know that we all here, definitely support you and feel for you and admire the work that you and HealthRight is doing. So thank you.
Thank you, Miriam.
Thanks. So now joining me on the panel, at least both in person and virtually, are Dr. Kate Guastaferro, an assistant research professor at Penn State University and soon to be an assistant professor here at NYU, who will speak from the perspective of child maltreatment. Dr. Lawrence Yang, vice chair and associate professor and director of the Global Mental Health and Stigma Program, will speak from the perspective of migration stigma. And I'm going to talk a little bit about the perspective of public health disaster science. After we've offered some comments, we'll have a Q&A and hopefully engage everybody here in the room as well as online. So next slide. I mean, one of the things that is evident is we're really captivated right now by the moment, by the drama and the horrific images of what's going on in Ukraine, whether it's the video, the before and after pictures, imagining what life must be like, imagining the traumas that people are experiencing. But from a disaster science perspective, we think about this a lot as disasters occur. Next slide. And what we think about is it's the aftermath. That's also something that we really need to start thinking about even now. The recovery, the what can be done now, what's going to make populations more resilient now. The event phase itself takes the most media attention, but it's the recovery phase that requires the most in terms of time, funding, investment, stick-to-itiveness. I mean, it actually requires, in disasters, 80% of the funding goes to recovery. And so obviously Ukraine is not at that point yet. Hopefully they'll be at that point as soon as possible. And all we could do now is hope that the event ends so that they can move towards the recovery phase. But it's also important to start thinking about, what do we need to know about recovery? What do we need to know about the kind of services that will need to be in place and that maybe even could be in place now to help them accelerate their recovery when they have that opportunity. From the perspective of the displaced populations, we also need to think about, different types of displacement. As you heard Helena describe, a lot of the people are, as far as they can tell and they hope, temporarily displaced. They have evacuated their homes either within the country or to neighboring countries in Europe with the mindset of, I'm going to go back home, I'm going to return. Some of them have no idea what they're going to be returning to. Others already know that the homes that they left have been destroyed, and with them, all of their possessions potentially. And so there has to be some thought to, what does that mean for reconstruction, rehabilitation, resumption of normal life? Some people will decide, and when I say people, obviously it's not just individuals, but households, families, whole communities will decide to resettle elsewhere. And so there'll be an acculturation phase where these people who have decided that they cannot go back, or they don't wish to go back, or they don't have the means to go back, or perhaps they think life may be better where they've resettled, are going to have these issues potentially for years to come of how do they integrate themselves and acculturate themselves into a new setting. And then some will return after a long time away. So longer than an evacuation, but maybe less time than a resettlement. Some indeterminate time away, 1, 2, 3, 4, 5 years, and then they're going to come back to Ukraine. And what's that return going to be like? What are they going to find on their return? How are they going to be able to integrate themselves back into a community that they have been out of for all of that time? So some of this is also a question of, what does population recovery look like? Can we learn anything from disaster science that might speak to the experience of a population displaced by war? And what makes some people, some groups, some communities more resilient than others? Next slide, please. So there's a model that we've been working with, my team in particular, for a number of years that we call the socioecological model of disaster recovery. And it's really just a framework that allows us to think about, how do we look at a disaster, both before the disaster has occurred so people can prepare for what might occur, as well as what could we anticipate would occur down the road, and what has occurred? What have we observed among disaster-affected populations? And so if you look at the right side of the screen under what's essentially the outcome, the recovery process itself, what we've come to understand is that recovery may be a function of 5 different domains, each one important, each one working together, each one representing something important that has to be resumed, returned, or some element that comes back to stasis or balance. So one thing is obviously economic stability. People need to come back and find economic stability. They need to find housing stability. They need to come back and be able to have good physical health and mental health. And then they need to be able to adapt their social roles. And this is one that is often a subtle and less understood aspect of recovery, which is somebody might have been a teacher beforehand, before the event, and then spent years, in an exodus, in a diaspora before they were able to return, or before they've resettled elsewhere. And they may not be able to resume the profession they had before. They may not have the certifications that they're eligible for when they're in a new country. Whatever may occur, they may not be able to still maintain that status. And what does that mean for their social identity? How do they adapt that? How do they find a way for themselves to lead meaningful and productive lives when their lives have changed so dramatically. And so, you know, we see the images that Helena shows us on the video. We see this in the news pictures where, you know, there are bombed out buildings and the entire landscape has changed. And people's identity in relationship to that landscape will change as well. And they're going to have to find a way to make their way and resume their lives in that during that reconstruction phase. There's a lot here that can help as sort of mediation in terms of what can we do in between the disaster exposure itself and the recovery. Some of it is formal and some of it is informal. The informal that we found from disasters is social support, is perhaps the most important. But then there are many formal institutions, some of them conventional institutions like schools, like faith-based organizations, that are really critical institutions in rebuilding lives and being anchors for people within communities when they come back. Oftentimes they can be resources for people. They can provide tangible assets, but they are critical. Sometimes there are assets that remained in the community and have gone through the experience themselves. Sometimes they come into the community. Next slide. And then lastly, one thing that we've looked at in terms of resilience is what makes up a resilient community? What are the features of resilience that are so important that any population that has been displaced and is trying to find its footing either in a new area or back in their home area, what will they need? And these are the things that we've discovered that they need. They need social capital, human capital, economic capital, and political capital. Each one of these plays a critical role, and each one is building that capacity for somebody who has been exposed to a disaster or a war to be able to come back and renew themselves. So I'm going to stop there. We'll hold any questions for later, and I'm going to turn the podium over to Kate, who's going to talk about child maltreatment.
Get over here before you. All right, hello. I'm gonna kind of anchor myself in that recovery phase as well, and I'm speaking specifically about child maltreatment in this setting. So, child maltreatment is a public health problem. That's what it says under that part. So child maltreatment is an act of interpersonal violence towards infants, children, adolescents, done by parents or caregivers or someone in an authoritative role. This involves physical abuse, sexual abuse, psychological or emotional abuse, and then neglect. But neglect is all-encompassing, so it also includes medical, physical, educational, and emotional neglect. And just to put this in perspective, globally, it's estimated that 3 in 4 children between the ages of 2 and 4 experience physical maltreatment or psychological abuse. And then under age 18, as many 1 in 5 women and 1 in 13 men report being sexually abused. So child maltreatment creates lifelong biopsychosocial outcomes that span the gamut from obesity to re-victimization, other chronic conditions. So this is a public health problem. Next slide, please. So this slide is showing you in normal, let's just call it the normal times, what the risk factors for child maltreatment might be. And I'll just point out a couple. So child characteristics include being young, but also having medical needs or intellectual or developmental disabilities. Parent characteristics, here you see some big ones, right? Mental health, substance use, having a high number of dependent children. Economic instability can be a risk factor. And then kind of leveraging what Dr. Abramson said here, having a low perception of social support is a really high risk factor for engaging in child maltreatment. Look at the community and societal factors here. So in areas where there is a lack of housing or services, where there's high levels of unemployment, the risk for child maltreatment increases exponentially. You see also here places where there's social and cultural norms that are related to violence, or that increases the risk for maltreatment as well. So even in the best of times, these are the risk factors. Just think what this is like during a conflict such as the war in Ukraine. So I won't go into a ton of this, but there is a wealth of research that shows how disaster and war have a impact on child outcomes, parent outcomes, and community and social outcomes that extrapolate the circumstance and the risk for child maltreatment. So I'll just point out a couple here. From the disaster literature, there's a lot of work that shows when a child is exposed to a lot of stress in a short period of time, they have lifelong post-traumatic stress symptoms, if not a disorder, and high rates of depression, and there's a high comorbidity rate with those things. I thought this was kind of interesting. I looked at literature that looks at adolescents who were growing up during the Ugandan war, and adolescents who were growing up during that time had higher levels of PTSD, anxiety, depression, and suicide ideation than their counterparts who were not in that area. So we know that this situation is going to create a public health problem in the future, right? On the parent end of things, I'm bringing in COVID here. We know that when there's a high amount of stress, the risk for parent burnout increases, which means that the parents are more likely to engage in either neglectful or abusive behaviors. We know that when there's job loss and income reduction, parenting suffers, increasing the risk for maltreatment. And if you think at the systems level, at the community and societal level, we do not have a plan for providing services in a disaster or in a situation where people are being displaced. So when we have disrupted systems, we are missing children, right, or women or anyone who needs a service. And for me, that's particularly important when a child is in a situation and they need to be removed, which is never the goal, but could be important. If we don't have a system to hear what's going on or find out what's going on, then that child's not being removed from that situation. Right. So pulling from Helena's slides, okay, just to remind us, 60% of the IDPs are women, 24% are under 5, and then 50% are between 5 and 17. So we are talking about a lot of people that could be in a situation where child maltreatment is a possibility. Right. So I'm definitely not trying to say that this is a story that captures everyone's life. It's not ubiquitous here, but this came from a New York Times article written by Amanda Taub, and I pulled out a couple things from this article that I thought emphasized what Helena said, that the war in Ukraine has led to familiar problems. So these were already existing, but now they're heightened. This article quotes that 90% of the IDPs are women and children, and that families are separated. Helena spoke about this. This commentary talks about a family in particular who have been separated. The men and boys have not been able to leave Ukraine. A woman is on her own with her family in Poland. And the amount of money that they receive from Poland does not cover the daily life expenses. So she cannot afford to pay rent and childcare. So what happens in this situation, right? If you can't work because you have to take care of your kid, you can't pay for rent. If you choose rent, you're working, then your child is potentially in a neglectful situation. So it's a very difficult context to be in as a parent. And then I wanted to comment about education because according to this story, the school system in Poland had made slots for Ukrainian children to join the classes. Well, the spots of those that they've provided are full. So now what happens to the children who come and do not have a spot? They're not enrolled. Even though this area made that, opportunity available, there is a finite availability of that. So here, I'm a prevention scientist, and here are my 2 take-home points about what I think we can learn from Dr. Abrahmson's work, from literature. I think that we need to be proactive rather than reactive. Of course, this situation is different than anything we've seen before, but we know what could happen for some of it, right? So let's anticipate and be proactive rather than just reacting to the situation. Next. And then this, I feel very strongly about. We cannot use interventions or treatments that have been tested in other circumstances and expect them to work here. So think about a mental health service. You've got 14 weeks of sessions to get through. Is that going to work in this setting? It's a big no from me. So I think this calls for interventions that are, of course, effective, but that are also affordable with the limited resources available, that are scalable, that a number of people could implement, and that they're efficient. We're not wasting anyone's time. And so my takeaway is that prevention is possible, and if we are proactive rather than reactive, we could alleviate quite a bit of public health burden.
Great. Thank you. So next up will be Dr. Larry Yang talking about migration stigma. Larry?
Hello, folks. Can you hear me okay? Thumbs up.
Yes, yeah.
Thank you so much. I really wish I could be there in person. So I tested positive for COVID over the weekend, but I'm quickly on the mend. So just forgive me if I'm a little slower than usual. But I really want to thank, of course, Helena for taking the time during this, incredibly challenging period to be with us. Kate for traveling up from, Pennsylvania to be with us today, and then all of you for being there in person, and folks for joining us online. So let me share my presentation. Can you all see my slides? Thumbs up? Thank you, David. Great. So displacement and this concept of migration stigma. So someone had asked earlier about the different, displacement of Ukrainian refugees from Ukraine in this recent period. And so this map just illustrates exactly what Helena and David and Kate have been talking about in terms of the 5 million plus Ukrainian individuals who are now moved to other countries. So these primarily consist of countries that share a border, as Helena had just said. So Moldova, Romania, Hungary, Slovakia, Poland, Belarus, and Russia itself. So you'll see here that Poland has actually welcomed, at this count actually, nearly 3 million individuals from Ukraine. So I want to introduce this concept of migration stigma today, and it's a new one. So some people have done work in this area, but let me, explain the concept and then explain the opportunity, and then its application in Ukraine. So there are two areas. There's the migration literature. This refers to international migration and specifically to immigrants who reside outside the country of birth. So in this case, again, to be clear, we're going to restrict migration to refer to international migration, even though, of course, it can actually be internal as well. Stigma, we can understand as the core processes of labeling, stereotyping, setting apart, status loss, and discrimination. So when we put the two concepts together, we have migration stigma. Again, some folks have done work in this area, but we have, I am in the fortunate position to be, have this opportunity to lead this think tank opportunity this summer, sponsored by the Ernst Strungman Forum Foundation in Germany. So we'll be meeting in June of this year. And so we understand migration stigma to be the specific form of stigma that exists between migrants and native-born residents of immigrant-receiving countries. So migration stigma draws from these two areas to better understand and address the stigma, discrimination, and marginalization that is often faced by migrant, or in this case, refugee groups. And one critical thought that our group has already had is that it has bidirectional impact. So the immigration experience or immigration policies themselves can illuminate stigma. And on the other hand, we can also understand that stigma can in turn shape immigration experience and policy. So at this point of the war in Ukraine, we can really understand, at least again to this date, the policies of the neighboring countries, at least take Poland, for example, to be relatively friendly. So we took this information from the European Web Summit on Integration. This is just last week. So Ukrainians who leave Ukraine as a result of Russian aggression have the right to legally stay in Poland for 18 months. And so when folks arrive, the Ukrainian refugees arrive, they, to obtain a right of residence, as well as many other rights, services, and benefits, they need to apply for a Polish identification number, which to my understanding is not too onerous to do. Once they gain this identification number, they then gain full access to the Polish labor market, no work permit is required in healthcare system, and receive a one-off cash allowance. As Kate described earlier, and Helena as well, many of the refugees are women and their children. And so a number of the rights extend to that group. So children have the right to attend Polish schools on the same basis as Polish nationals. And they are entitled to many social benefits, including financial support for the child and school supplies, family care support, nursery school subsidies, family benefits, and social assistance. Of course, to the limit that is available, as Kate described. What is really interesting to me as well, actually I think noteworthy, is that the Polish government is also providing assistance to companies and individuals providing assistance to refugees from Ukraine. So basically, individual sort of actors who are providing accommodation and food will provide financial assistance for up to 60 days, up to 250 euros per month. So in essence, the government is actually providing support to individual actors who can then extend their goodwill. So at this point, I would, in the Ukrainian war, the war in Ukraine, excuse me, it really is, the policies, at least the policies, right? The reality on the ground, of course, may differ, but the policies are, relatively welcoming. So let's just take a look at a headline from 2 days ago in the New York Times. I guess the question is, right, and of course it's our fervent hope that it will not, but could these policies change over time as resources become strained, as more and more refugees enter? So this headline reads, Warsaw's welcome mat risks fraying under strain of new refugee surge. And so there's a potential second wave of refugees from Ukraine due to the renewed, basically, assault of Russia on the eastern front of Ukraine. So Ukrainian refugees have already increased in Warsaw's population by about 20%, and could be an additional surge on top of this. Here you can see a picture of Ukrainian refugees lining up in Warsaw to receive this Polish identification number. Much of the aid has been provided by local governments, please forgive the typo, NGOs, private charities, and individuals. And out of the about 300 refugees into Warsaw, about 70,000 have been provided housing in office blocks and sports halls, but far more have found shelter with individual citizens. So again, a lot of the good that's being done is through, again, these individual charity. And, there's a question of how long, this goodwill could extend for. And hopefully, it will extend indefinitely, but this is something just for us to really be mindful of. So if, this concept of migration stigma were to occur at some indeterminate point in the future, where could we sort of look towards, how it could occur, on what populations might it unfold with? So borrowing from the migration literature, there's a very old and influential theory called group threat theory from 1953. And this theory has been used to understand native-born reactions to immigrant populations or refugee populations. So Bloomberg defines prejudice as a response to perceived threat from an outgroup, or again, refugees, due to competition for jobs, welfare benefits, and other material resources. And this also stems from perceived threats to homogenous national culture. So what's key in this theory is that it's not just being a native of the host country, it's who you are in terms of your group position. So this theory proposes that the perceptions of threat tend to be greatest among native-born of lower socioeconomic status, who are more likely to compete for resources with migrants. So in this scenario, this theory would propose that it would be the folks who are of lower socioeconomic status in Poland who might be, in conflict at some point with the refugees from Ukraine, and that this group might be the one that might be most vulnerable or susceptible towards, developing prejudice. Thankfully, to my knowledge, this hasn't occurred yet, and hopefully it won't. But if it were to happen, you could imagine that it could occur first in this group. From stigma, we can then borrow what we call a multi-level conceptualization of stigma, and I'll just walk you through it very quickly. But what it does is it gives us a map to understand how stigma could take place and also potentially how to interrupt a stigmatizing process. So let's say that, a group starts to develop stereotypes towards, the Ukrainian refugees. And we can draw from many examples within the United States for this phenomenon. So, the way that the United States labels certain immigrants as freeloaders or loafers, or not deserving of the sort of the benefits that the US provides. So, if a group was stereotyped in that way, you can imagine that you could have internal psychological processes. If you were from that group, do I belong to this country? Do I actually deserve these benefits, et cetera, et cetera? There could be interpersonal social processes that emerge between the individuals and groups, so stereotyping and prejudice that then occurs towards the refugee group. There could be everyday life activities that matter most that lead to daily conflict between groups in the context of migration. So for instance, if there are language differences, religious differences basically in the ways that everyday life is lived within the two different types of cultures, and that these could then lead to basically friction and conflict. And then lastly, our structural processes, including politics, culture, and social policies, immigration policies themselves. You could imagine, and we've seen this play out in the United States, where when there's societal backlash towards an immigrant group, then policies change in response. And you can imagine over time the possibility of this occurring in Poland and other countries surrounding places like Ukraine. So like my colleagues, I wanted to just provide these, these thoughts, these frameworks, social behavioral science frameworks, to really give us a way to think about, public health problems as they emerge, perhaps even before they emerge, so that we can really gain a foothold to addressing them, before they grow to such a large magnitude. So I want to thank you all for your time and attention, and I'll turn it back to David.
Great. Thank you, Larry. So at this point, we'll open it up for questions from the audience here and from the online audience. And if you don't have questions, I'm sure I can think of questions to ask my colleagues. Alice?
So thank you very much for all the presentations. This is really, I'm Alice Fothergill. I'm a disaster sociologist. I'm a visiting scholar, so I don't know many of you, and I'm based in David's Center for public health disaster science. So, and I study disasters, and this has been such an important discussion about all the various layers, and I really like the focus on prevention and really thinking things through. So this idea that these host communities are going to, as you said, the welcome mat fraying. That's, so thinking things through before maybe things happen. I have so many questions, but David brings these important points up about communities and resilience. And then Kate brings up this idea of thinking about interventions. I guess maybe I'll start actually, Kate. The question I'm thinking of is, I am intrigued by your comment about interventions, making them scalable, effective, efficient. And I was wondering if you might say a little bit more about what those interventions look like for children.
Well, thank you for your question. I will just say that this statement and this idea about interventions that are effective, affordable, scalable, and efficient is actually Dr. Linda Collins' the multi-phase optimization strategy and how to develop optimized interventions. So what I'm essentially calling for here is using MOST to create optimized interventions to meet the needs of the people of Ukraine. Would you like me to say more, or does that?
Yeah, I mean, if you don't mind, I'd
well, so
just
let
like
me
to
just give you like an example of what I'm
that would be
thinking.
awesome.
So I do child maltreatment, right? We have interventions that could take 18 weeks to see a change in a parent's behavior. Okay, let's just think about how that 18-week session would go in this environment. They absolutely need the service, right? But it would be a lot to ask them to sign up for 18 weeks of that session. So my question then becomes, empirically, do we need all 18 sessions in order to see a change in the behavior that we're trying to change? So using something like MOST could help us empirically create an intervention that is effective and done within a limited amount of time or for an amount of money. So that's my example.
Yeah, great. Thank you very much.
Yeah, thank you.
Really helpful.
May I chip in there with Kate? So yeah, there are some mental health interventions as well that are widely being used now, and they are, there's one that's called Self-Help Plus. That actually, it's a great intervention for war displaced communities, because it's actually it's like a self-management kind of intervention. You do need to run through several sessions. There need to be, I think it's 3 sessions sort of that can take place either virtually or in person. But then a lot of it is actually then kind of self-managed through apps and the like. Of course, there are a lot of limitations there as well, but at least it offers the possibility of rolling out some of these services to folks that can't reach live human professionals.
I'm just gonna. Can I just stand here so we don't have to dance? Okay.
So, and also when you ask your question, I realize introduce yourself, because that would obviously make a lot of sense.
Hi, so my name is Haley, and I guess at first I want to preface this by saying that I'm really glad that Europe is mobilizing to help Ukrainian refugees. However, I have spent substantial time there working on the European border in the earlier refugee crises with namely like a lot of Afghan and Syrian refugees. And so to be honest, it was really hard to hear how much they're willing to give for Ukrainian refugees. And so I guess I have 2 outstanding questions when it comes for one for Dr. Yang. When it comes to stigma, what is this I imagine it has to be hugely compounding stigma for the Afghans who are seeing that this just getting passed over. And then for Dr. Gustafaro about you made a comment about how we've never seen this before and how we don't know what interventions are going to look like, but we have seen this before and interventions didn't happen. So I guess what is your thoughts on if interventions will actually happen and their longevity, and what we can do to make sure this is inclusive of all refugees and not just Ukrainian refugees?
Thank you for that very, insightful question, as well as profound one. So, right. So you'll notice when I did talk about migration stigma, and I didn't talk about other groups. And it's true. It's absolutely true. And I'd be curious to hear actually more about your experiences of it. Actually, we can continue this conversation offline because I'm very eager to learn more about it actually in terms of other exactly refugee groups and how they've been received in Europe in these different European countries prior, to the Ukrainian crisis. Because right, some groups are just treated differentially. And what's the basis of that? Questionable, right? I mean, in this case, we have a very clearly, delineated war that's happening with a neighbor. But you can make the same argument that the Syrian refugees were under the same type of situation and under the same types of duress. So why didn't they receive the comparable type of embrace, right, from Europe and different countries that the Ukrainian refugees are? So I think that's absolutely a fair question. And that's something that, has to be really, I think, really thoughtfully considered and answered. And secondly, I'm glad you raised the point around exactly the fact that if someone sort of gains status, right, in this case, is Ukrainian refugees are let in, under these relatively permissive, laws, then, by extension, another group gets bumped down. So it's absolutely, critical for us to keep in mind exactly the even more displaced and marginalized communities that have been probably going through this type of experience for quite some time. So I want to thank you for raising that very important question. I'll continue to consider it.
I'll just echo, I thank you for asking that, and I most certainly am not trying to minimize any other conflict ever. I agree with you. We should always make interventions available, and I think that potentially brings in the importance of implementation science within this setting and figuring out ways to make interventions work no matter what the setting is. And so, great point. I'm sorry if I...
Oh, I wasn't trying to call you out on all of it.
Okay.
More so just bring up a point that we have seen this before, but we still have to say oh, we haven't.
You're right. You're totally right. Good point.
So actually, I want to make one comment about that, which is a lot depends on political representation and storytelling and how the conflict itself is contextualized, how the people who are victims are contextualized. That's going to have a huge impact on how other countries are responding to them and receiving them. So in part, if the other countries feel that Ukraine is fighting a war on their behalf or is doing something that might be something that could have happened to them, and that there's an aggressor out there, that has threatened this other group, then the other group is more like them. And that's always going to be the case is, how much othering is occurring, how much homophily, how much can you say this group is the same as me because they are potentially being threatened by, a similar aggressor. The enemy of my enemy is my friend kind of routine. So that political representation is important as well as how it evolves over time. Because if that changes and the politics change in any of these receiving countries, I would hypothesize that the stigma will go up right at that moment.
Oh, yeah. Hi, Dr. Yang. Hi.
And introduce yourself.
I'm going to, thank you. My name is Jenna Delashne. I am a student in global public health, and I'm also on the faculty of numerous organizations that offers mind-body practices for trauma and resiliency, which are scalable. And what I was and I'm familiar with Self-Help Plus, including some of the colleagues at HealthRight. What I wanted to talk about is this concept of the othering that occurs because of dysregulated nervous systems, and that increases stigma, because it's all based on fear, right? So if we can work with people in the intake centers on regulating their nervous systems, which will help regulate the people that are coming to see them. And for parents who have more regulated nervous systems and who are more safe and secure attachment figures for their children, it will help them, right? So it's kind of a trickle-down effect. And then what we have to address is the effect of children's mental health on their parents. And I've been working for many years with an organization called Second Response, which tends as a second response to the emotional and psychological care of children utilizing practices, which I'm happy to talk with you about at another point. But it's all interrelated.
Yeah, so thank you, and nice to meet you. Let's chat. I think maybe just one thing that's coming up with what you brought up, and you tried to ask this with Helena, is the self-care of those who are providing services. And I think that is also an important focus of our efforts through the event and into the recovery phase. I think that's important. And then I agree with you that we have to recognize the bidirectionality of these relationships. And so I'm just validating and echoing what you said, but I appreciate the point.
Sure, yeah. And we're seeing the burnout everywhere.
Yes, I have a question. Bill Rahm. My question is about the recovery phase and how do you pay for it? Because the infrastructure is being destroyed daily. The apartments, the homes, the bridges, the hospitals, the universities, the schools, everything has a giant hole in it and has been destroyed. And it seems to me there's an obvious money stream from the Russian kleptocracy, that the oligarchs have a lot of money here in New York on their yachts, in Aspen with billionaire homes. How is this confiscated legally? How is this sold? How is this money put up in a fund to help Ukraine?
So there's actually an urban planning professor named Rob Olshansky who has written about this problem called time compression in the aftermath of a disaster, which is essentially that however long it took to build Ukraine and the areas that were destroyed, let's say it took 50 to 70 years to build up most of the infrastructure that you've witnessed being destroyed, it's going to take 5 years to rebuild it. So problem number one is you have to compress all of that development into a very short period of time. And that, in and of itself leads to lots of issues and problems about how do you do it in a way that's sensible, sustainable, etc. Then you have the question which you've raised, Bill, which is how do you pay for it, which is both a political and an economic question. I can only hazard the guess that politically, the first thing that would happen is all the donor nations would, try and stake a fund for the reconstruction, and there will be a considerable effort to try and make Russia create restitution for the damages that they've done, either from the force of political pressure or through judicial efforts to do so. How successful they are, who knows?
Hi, my name is Nagin Fathi. I am a global public health master's student right now. I have a question for you, Kate. So you mentioned being proactive rather than reactive. And just logistically understanding that, what do you mean by that in terms of the timing of it? Given that things have already happened, so we can't be extremely proactive now. And to some extent, it already will be reactive given the time. And do you think the implementation of that, or do you plan for the implementation of that to be back in Ukraine or in host countries, like all of the above?
So I am emphatically going to say that I do not have the answer to that, but from my perspective, what I mean by being proactive rather than reactive, which is a bit of a tongue twister, is we can't wait for the war to be over before we start planning for or enabling the delivery of services. And maybe it's not, as designed, but there's a need now, so why wait is kind of my point about being proactive rather than reactive. And I feel like the implementation of it should be flexible and, that axiom that you meet the people where they are, right? And I feel like we have the interventions and the ideas, so let's just get them to those who need it rather than waiting for them. This is totally just my opinion, but that's kind of what I mean by being proactive rather than reactive.
And through that, do you think that the most viable solution will be providing like virtual opportunities? Slash, like, do you think even that would be feasible once people go back?
I feel like I did not ask her to ask these questions, but I think you raise a really good point. So I think that virtually delivered programs are great because they create access even in any environment, right? My problem is that we cannot assume an intervention will work the same online as it does in person. And so I'm just a little cautious about you roll out everything virtually, but we don't know how that works. And so just as a little example here, again, child maltreatment, a co-occurring circumstance that happens with that is interpersonal violence. And so let me just paint the picture where I'm on Zoom working with a mom talking about keeping her child safe, and I don't know what is happening behind her or what's in the room with her. And so I feel like we can't just assume that session is going to work the same way, and we have to adapt our interventions to work virtually as well as in person. But I do think that being systematic and being thoughtful about that rollout could create a greater access, especially in this situation. In the same breath, we cannot assume everyone will have access to the technology that's needed to do that. So I don't think it's a solution. I think it is part of a solution.
Mm-hmm.
So one thing that that struck me really as a part of, like, as a feature of this conflict was the use of social media. There was a lot seen on TikTok, on Instagram stories from actual people that were going through this situation. So Dr. Abramson, what do you think of leveraging social media as a method of risk communication? And then that kind of ties into Dr. Gustafaro, what you said, and Dr. Yang, about can we use it potentially as a means for educating and then mitigating the othering and the stigma, and then creating context to adapt intervention. So I know I kind of linked it to everything, but essentially, how can we leverage social media in this situation?
Right. So, and thank you for that question. And it's something that comes up a lot in my risk communication class, is the use of social media, both the positives and the negatives that are associated with it. So setting aside the negatives and the mis and disinformation and the potential for stigmatization that can occur on social media, there is also the potential for the creation of community, for the creation of the kinds of capital that I was referring to before. It can definitely enhance social capital. And for those who are sociologists in the group, you can appreciate that there are different types of social capital, bonding, bridging, linking, and different types of social media facilitate different types of capital formation. So just having a group of others that you can communicate with, that's a small group, will be very effective. Finding resources across groups where you might even be crossing a power differential or a status differential could be useful. So there are a number of ways that it can contribute to social capital. In terms of political capital, we've seen many times how social media can really elevate a group's political capital and the ability to leverage or influence the distribution and acquisition of resources to a community that needs it. It can put a spotlight on something that's happening. And then in terms of human capital, I mean, it's, we've seen again and again that the ability of social media to allow people to work, to engage, to do new types of activities and find meaning, number one, and meaningful work through social media and internet-based activities could also be a huge advantage, particularly to a displaced population. So from all those perspectives, I can see many positives, as well as the negatives that I will hold in abeyance and let my colleagues talk for a minute about it.
Larry, do you want to say anything?
Hey, please go first.
Okay, so I think I agree that there are a lot of concerning things that could happen, obviously, but I think you're right that we could leverage social media a lot. Again, coming from a prevention perspective, starting with education. So yeah, we've been talking a lot about what it would mean to provide services to the people in Ukraine. But what about thinking about a different intervention, if you will, to those of us who need to be educated that this has happened before, that we could learn from prior experiences. So maybe that's not a behavioral intervention, but it is certainly a starting point in educating people. Social media is tough, right? But I think it could be done well with probably some empirical studies around it, right? Yeah.
Yeah, and I'll just chime in. So, there's this intervention method called in stigma intervention. It's called interpersonal contact. It's a very fancy term. Basically, it's just you want to basically humanize the experience. You want to see yourself in the person who could be othered. I thought when Helena, for instance, showed that video, even though we weren't able to hear the sound, the images were so powerful because there's a park, there's a mom and her kid walking across the park, that you've seen that probably many times. That could be you, right? And then in the next frame, there's this horrific bombing occurring. So obviously, so the feeling being that could also be you. So that engenders incredible sympathy, empathy, and humanization of a group that could potentially become othered. I would also say that we could utilize this approach, an extension to other groups, not just Ukrainian refugees, but all refugee groups, really, in order to create this common human bond that can then reduce and mitigate stigma. I just want to, before we end, I just want to say one thing. I also just want to publicly thank David Abramson for stepping in and emceeing this literally on the last minute, because both Ralph and I, for different reasons, couldn't be there in person. So I'll public thank you.
And with that, I want to, first of all, thank everybody who showed up in person and online to listen to this. I think, this is a very challenging moment, obviously, in the world. There are lots of challenging moments that happen all the time. This is another one that's coming, and it's, something visible to us day by day. And, it's something that I think a lot of us in public health look at and say we want to be able to do something about it. Of course, we find ourselves saying that constantly by what we see in the world around us. This is yet one more thing we want to do something about. This is something that we probably have to do something about. These kind of discussions are meant to be the beginnings for us of how can, at the very least, the Faculty of Social and Behavioral Sciences, our students, others we know in the field, begin to think about the things that we can do, either to do in terms of research, in terms of policy work, in terms of encouraging different types of practice. So all of those things are to come and to be done. Thank you to my colleagues on the panel. This was terrific. We appreciate it, and we look forward to seeing you at other such panels. Thank you.